since Dr. Manish Rathi is not coming onto the dais till I introduce him to the audience. So now I introduce Dr. Manish Rathi. He is the professor of nephrology at the prestigious PGI Chandigarh, and is also the honorary ex-former secretary of Indian Society of Transplantation, and is a mentor-mentee awardee from the TTS ISOT 2017-18, and he has several fellowships, so several orations, and many more to come also, which I can enlist and further. And is a wonderful speaker and a good researcher with more than 200 publications to his credit, and he's actually lupus nephritis man of India, but still he can talk something related to the CKM, which is an important topic for all of us. We have been discussing a lot about the diet. Actually, diet is more to be enjoyed while eating, but still we can listen to the authoritative personality, Dr. Manish Rathi. Dr. Manish Rathi, please.
Thank you, sir, for wonderful introduction. At the outset, my gratitude to Dr. Swanlata and her team for arranging this wonderful conference and also inviting me here. So, since morning you all are hearing about diet. How many of you are tired of hearing diet? Just raise your hand. Anybody tired? Just few of you. I thought there are more people who are tired. So, those who are tired, you do one thing, get up from your seat and raise your hand and calf raises for 5 times, you will feel better. So, sorry? Okay. So, you will feel better, right? So, topic is CKM syndrome, and I think Dr. Narayan Prasad has already talked about this in his wonderful oration, where he talked about what is CKM and what should we do about CKM, but I will be focusing mainly on the diet part, that what is diet part in our CKM patient. Most of it you have already listened to it, some of it will be repetition, some of you may find some important new information in my presentation. So CKM, what is CKM? So there are 3 components in CKM: cardio, kidney, metabolic. So it starts from metabolic, but somehow M is in the last, but it should be in the beginning because metabolic comes first, metabolic disorder, metabolic syndrome comes first, and then it subsequently leads on to either kidney disease or cardiac disease followed by kidney disease. So this is combination of 3 things occurring in a single patient. And usually cardiac takes precedence over other things, and patient usually die because of cardiac disease, and that is why C is first in CKM. And pathophysiology, we all know this is combination of factors. So patients are obese, patients are diabetic, they have lot of adipose tissue, inflammation we have already talked about. So this becomes a vicious cycle. So one thing leads on to another, and another thing leads on to third, and third things lead on to first. So it goes on and on. So that is why it requires intervention, early detection as well as intervention. Again, this picture you have seen previously. So there are stages of CKM. What is important here to note is stage 0. If we go by stage 0, we all are in stage 0 of CKM. So stage 0 is basically we don't have any risk factor, but we have to prevent ourselves for going into CKM. So this is known as primordial prevention, and then there are subsequent stage 1, 2, 3 and so on. CKD comes as early as stage 2. Cardiac subclinical comes in stage 2, but then predominantly in stage 3. And by and large, the most common is stage 2 kind of thing where CKD is already set in. So this is important for us as nephrologists that CKD is already set in, and this is the most common group of CKM. Now here is a case, if you are feeling tired, just to energize yourself. This is a 48-year-old male with sedentary lifestyle and had weight gain, known case of diabetes and hypertension, and these are his parameters with high BMI, high waist hips ratio, BP is high, HbA1c is high, LDL is high, EGFR is low. So how many of you think this patient has CKM? Just raise your hand. Only 1, 2, 3, 4, 5, 6, 7. So none of the backbenchers. I love backbenchers, so that is why this question is for you. None of you think that this is a CKM? Anyway, so this is a CKM. This is a classical CKM patient. You don't require all of the things to be present in the given patient. So this is already established. At least it will be a stage 2 of CKM. And if we look at the dietary pattern of CKM person, this is the typical dietary pattern of a CKM person. So they will be eating a lot of fast food, they will be drinking Cokes and Pepsis, they will be having high sodium content, they will be taking fried foods and minimal fiber. So this is the typical dietary pattern, and this is the typical dietary pattern of Indian young generations also these days. So this is kind of fuel to forming CKM. So that is why we are talking of nutrition. So nutrition is central. As I have said, it starts from metabolic syndrome. So we have to control metabolic syndrome at the outset, and diet plays a common role. And also it is a scalable thing. So what happens is that not only in the primordial prevention diet will be important, but once the CKM is already established, then also diet has a role. So at all stages of CKM, whether you are giving pharmacotherapy or not, whether you are giving any other intervention or not, diet is must for treatment of CKM. And this you all have heard since morning, that what are the recommendations for CKD patient. So if we talk about protein, the protein is 0.6 to 0.8. But remember, earlier speakers have also said that even this protein intake is not obtained by our patients. Even we ourselves will not be able to take this protein unless we count it for ourselves. I think since last 1 year or so, I have started taking 1.2 to 1.5 grams per kg body protein myself, and it is very difficult to consume this much of protein. So forget about 0.8 grams. As earlier people have said, our patients or general public or even us doctors will not be taking 0.8. I am sure half of you will not be taking 0.8 grams of protein in your daily diet. Similarly, calories, 30 to 35 kilocalories, and again previous speakers have said that we are not taking even this much of calories. So we are calorie deficient, we are protein deficient from beginning itself. And there are other restrictions also, like sodium should be restricted. Potassium is important. So unless your patient is having hyperkalemia or is on multiple drugs, potassium is actually beneficial. So you should not advise restriction of potassium in your patients. So potassium should be individualized. So coming to individual components, so what about carbs? So when we talk about carbs and when we say that 30 to 35 kilocalories should be coming in the diet and almost 50% of that should be from the carbs, we should also be that one carb is not synonymous with other carbs. So we should be advising them complex carb rather than simple carbs. And this is the picture which depicts what is the difference between simple and complex carbs. So simple carbs, what it does is it causes a spike in the blood sugar level, spike in the insulin, and it causes insulin resistance and adiposity and metabolic syndrome. So we should be giving complex carb to ourselves also as well as to our patients also, and avoiding simple carbs like simple sugars and Cokes and other things. Similarly, this is protein we have already talked about. There are recommendations that they should be restricted for protein. Somehow they are already protein deficient, as has been discussed in the previous talk. So we should not be enforcing too much of protein restriction, as Dr. Tarun has also said. Even at least in dialysis patients, you should not be talking about protein restriction. So not only protein intake is important, what kind of protein you take is also important. And there was a big debate since morning that plant-based versus mixed versus animal. So what is important here to note is that animal-based protein should not be the dominant form of protein intake. That is true. That is clear. That should be clear to everyone. Whether you are specifically advising plant-based only or a mixed diet, you forget about that. But at least the predominant component should not be animal-based protein. And there are reasons. Specifically for CKD patient, it causes acid load, it causes phosphate load, and it causes inflammatory load. So there are many reasons why to avoid predominant animal-based diet in our CKD patients, and they should be on predominant plant-based diet. What about fat? So fat, out of total cal, the fat should be coming around 30%, that is about 1/3 should be coming from fat. And when we talk about fat, it should be coming from predominantly unsaturated fatty acid, that is MUFA and PUFA. You have to restrict your saturated fat. And again, this picture demonstrates what are the important sources of MUFA, that is monounsaturated and polyunsaturated fatty acid in your diet. You should also try to increase their omega-3 fatty acid. Now we have enough evidence that even in dialysis patient, if we give something like fish oil capsules, their outcomes are better. Now talking about certain dietary pattern-based diet, which we have again listened since morning. One is DASH. DASH is basically dietary approach to stop hypertension. So what does it? It is mainly a plant-based diet, and it has increased increased potassium and reduced sodium intake as per the dietary pattern. And DASH diet is supposed to improve your blood pressure and cardiac outcome. Then we have Mediterranean diet. So Mediterranean diet is also similar to DASH in form of that it is also a plant-based diet, predominant. But here the important component is olive based, or olive oil is an important component. So they focus too much on olive oil, which is not there in DASH diet. And there is a modification of, and another good thing about Mediterranean diet is that they have also talked that you have to focus on the local dietary pattern, which is not there in the DASH. So somehow Mediterranean is somehow better because they tag that you have to modify according to your local dietary pattern. Then there is a modification of Mediterranean diet. I think there will be next slide. So this is comparison between Mediterranean and DASH. So you can give a combination kind of thing. So DASH along with olive oil becomes a combination of Mediterranean and DASH diets. And we have enough evidence that these diets are important. If we use certain these kind of dietary pattern, then there is significant reduction in the cardiovascular disease outcome and reduction in the diabetes. Yeah, so this is the modification of Mediterranean diet for CKD patient, which is known as modified Mediterranean diet for CKD, or an acronym of MEDRAN diet kind of thing, where protein is restricted and salt is restricted and phosphorus is restricted as compared to Mediterranean diet. Other things are predominantly same as compared to Mediterranean diet. Now, lot of things have been talked about this Plado and Plafond. So, Plado is basically plant-based diet. Plafond is plant-focused diet. Both things are same. It's that everybody wants to give their own nomenclature or acronym kind of thing. Both things are same. Now, important things to remember here is when we talk about Plados or Plafond, what does it say? 80 to 85% of your cal should come from plant. So 15 to 20% can come from animal. So it is not a pure plant. It is not a vegan diet, right? So when we talk about plant-based diet, don't say that we have to restrict non-veg diet. If patient can take eggs, if patient can take non-veg, it is allowed as much as 15 to 20% of total calorie intake. And similarly, if we talk about the protein intake, at least 50% should come from plant-based diet. This is, so 50% can still come from animal-based diet. So this is important to remember. Don't go into this debate of plant-based versus mixed diet. You have to give whatever the patient is taking, and you have to modify your diet accordingly. And both things are same as I have said earlier, and these are the parameters of Plado and Plafond diet. The important thing is, which I have said in the morning, is flexitarian diet. So we have to be little flexible. We should not go by this rigid dietary patterns that we have to follow DASH or Mediterranean or Plados or Plafond or whatever. Flexitarian diet, that you give flexibility. You give flexibility to the patient to choose which diet they have to follow, what is their dietary pattern, and then you go around that dietary pattern and modify that dietary pattern to give them the most appropriate kind of diet. So coming back to our case, I have shown you what type of diet he was taking and what we have done. So in addition to pharmacotherapy, we have done all these restrictions. So we started him on plant-based diet. It was not plant-only diet, plant-based diet, which was calorie restricted, salt restricted, protein was 0.8, high fiber, and avoidance of all the ultra processed food which he was taking. And after 6 months, this was the outcome. So significant reduction in weight, significant improvement in HbA1c, improvement in blood pressure, the GFR established, and proteinuria reduced. All these things you can take care just with dietary intervention. Another important thing which I think has been talked in morning, maybe not in detail, is the GI index, or what we known as gut microbiota index. And again, the plant-based diet is more favorable for your gut microbiota. So you have, this is another reason to give a predominant plant-based diet, that is, they increases your friendly gut microbiota and decreases your disease-causing microbiota, which is bad in animal-based protein. So this is another reason for giving a plant-based diet. Now, when you should start advising diet? You know, we have talked about stage 0 and primordial. Now here people are talking about in utero. So when the baby is conceived, you have to target the mothers. You have to target the diet in the mother so that their genes are programmed in that manner that they are not predisposed to development of CKM in future. So this is the level people are going. So we are talking about dialysis patient nutrition, and people are talking about in utero kind of intervention where they are targeting the mother's diet to look into what should be done for CKM. So what is the practical implementation? So this is the practical implementation kind of suggestion. I think this was again suggested in previous talk, that you think that we are giving a complete plate and then you divide that plate into 3 parts, half, 1/4 and 1/4. And this should be the composition, a rough composition of your plate to your patient. So 1/4 should be containing protein and 1/4 should be containing carbs, which should be complex carb. And remaining half of the plate should be containing fiber-rich, antioxidant-rich kind of food like vegetables, like your fruits. You can take into consideration the potassium content and other things. So this should be thing. So what should be done in Indian diet? So this is kind of suggested recommendation. So again, as I've said, in Mediterranean diet, they said that you have to target whatever they are eating. So diet in south will be totally different from diet in north, which will be totally different from diet in west and diet in east. So everybody has their own way of taking food. So here you will be having predominantly idli and dosa kind of thing, which is not there in north. We have predominantly rice and wheat based, while in west it is predominantly millet based. So according to that previous picture which I have given, you further modify this according to the region where you are practicing and the dietary practice of the patient which he is having. So this is the final slide, master slide. So if you find these are the stages of CKM, and the diet is the intervention in all stages of CKM. We have talked about primordial, but I have also shown you the fetal in utero kind of intervention where now people are targeting that they target the gene modification, that they modify, not actually modification, but you know, adapting that gene to that kind of dietary environment that they will not be predisposed, they will not have craving for fast food or other things maybe in their adult life. So thank you very much for your patient hearing. Happy to take any questions.